Works for me.
All right, thank you everyone for joining us this evening. Whole Health spends a lot of time working in the adult immunization area, and this is our recent iteration of that program, and we're looking forward to sharing it with everyone joining us tonight. The topic is called Beyond Flu, and this year we've been devoting a lot of our energy, Tiana and I and our team, empowering our pharmacists to make strong recommendations for their patients with regard to additional immunizations that we can offer them, in particular when it comes to protecting our airways during a climate of COVID. So I know Tiana has a lot of helpful information, and I will chime in as well and add some flavor to that. And you know, we only started our program, actually we kind of kicked it off early, doing like a blended flu and pneumonia campaign this year at Whole Health. And we're already seeing really great results from our pharmacy teams, hearing back how they're making recommendations to other prescribers in their communities, and those recommendations are being acted on. So our pharmacies are really, and I'm quite proud of how they're stepping up and protecting their communities towards other diseases and a larger public health role. So it's been a really exciting year with us so far. I will take a moment to introduce Dr. Tiana Tilley in case anyone on the line doesn't know Tiana. Tiana is the mastermind behind a lot of our professional programs here at Whole Health, and her title is Director of Pharmacy Innovation and Professional Affairs. It's a pleasure to work with Tiana, and you'll hear a little bit more about what she does tonight. Yeah, so with that, I will carry on. And of course, I'm James Morrison. I should introduce myself as well in case there's somebody who doesn't know me. And what I do for Whole Health is mainly operations. So Tiana, let's go to the next slide. So I'd like to take a minute to thank Pfizer. Pfizer has been very supportive of Whole Health programs with adult immunization. And this year, again, they provided a grant so that we could supply some of these resources for our pharmacy teams. So thank you to Pfizer. So this is the agenda for tonight. We'll begin with a bit of an overview of our trajectory into this space of adult immunizations and showing how under Tiana's leadership, our program has really expanded over the last year or two. And we have some really interesting results that she'll share with you. We'll talk about vaccine preventable diseases and several different ones. So you'll see through the guidance Tiana is going to offer how when you look at a patient before you, there's a good chance there might be an immunization that they're missing, and there's a real opportunity for you to fill that gap with a proper immunization pending your assessment. Towards the end, we'll talk about adults, operationalizing adult immunizations, and some tips and tricks and some tools and resources that we have available. If you are outside of Whole Health and you would like to have access to some of these resources, you're welcome to reach out to Tiana or myself, and we can help you with that. We do have a section at the end for Q&A. However, I will be monitoring the chat, or the chat and the Q&A on Zoom, as well as the Facebook live stream. So if there are questions, you're welcome to put them in any of those places, and we'll do our best to address them. So Tiana, I will pass it off to you.
Thanks, James. Thanks for the introduction and for joining me today on our webinar to add some colorful commentary and also some experience and some tools and tips about operationalizing these programs. So far, people who have been with the banner for a while know about this, but for newer members, just highlighting that we have had really good success with our adult immunization program. We started back in 2018 with just the pneumonia campaign, and then we've slowly been adding on as we became more and more comfortable making recommendations for adult immunizations. It's spread to include meningitis as well as herpes zoster, and today in our session we're really reviewing adult immunizations more holistically, and really pushing it not just in flu season, but moving beyond and calendarizing it into your entire year and your entire practice. So it's really, really nice to see the great uptake, like James was mentioning, that we're seeing already this year. I think there's a really big openness to immunizations kind of in light of COVID-19 and a lot of the discussions that have been going on about vaccines and a COVID vaccine. And that's really made people aware of how important immunizations, when they are available, are. And I've already received a lot of emails from a lot of you at the different whole health pharmacy locations, really excited about your pharmaceutical opinions being accepted and patients receiving 2 or 3 vaccines on the same day. Some questions about how to do that, which we'll talk about today, but it's really great to see the success you're having already. I also wanted to highlight that we have looked at our adult immunization programs and really vaccine uptake more through a research lens in the last year or so. And so we ended up looking at immunization uptake back in 2017 when we didn't have a program, and then compared that to 2018 and 2019 where we did have a pneumonia campaign happening in November. And this is the poster presentation that came out of it, which was accepted for an international audience, so at ID Week as well as ASHP. So if you're attending either of those conferences, you can see our poster presentation there. But the big thing that I wanted to highlight is that we found that vaccine uptake increased during months where there were campaigns, so predominantly in November, as you can see with this big spike here in red. And the nice thing is that that uptake actually was sustained throughout the year afterwards and months following campaigns. So what you're doing, the initiatives that you're participating in, does lead to increased uptake, which can help with increased protection for your patients and additional dispensing of these vaccines and administration services for your independent pharmacy. Okay, so without further ado, we'll talk about vaccine preventable diseases and how you can take on a bigger role in protecting your patients from them. So one of the big things that I want to call out is that Canadian immunization rates are not at target. So NACI has put out coverage targets, which for things like influenza and pneumonia are 80%. So we want 80% of the Canadian adult population to receive an influenza and a pneumonia vaccine, at least one pneumonia vaccine. But when they did a survey of Canadian adults, they self-reported quite low immunization rates, significantly below what our coverage targets are. So for influenza, we see across age groups and categories that there's only about a 42% vaccine uptake. And for pneumonia in patients 65 plus, we see only 58%. And that's actually even lower amongst younger people who have medical conditions that put them at risk for pneumococcal diseases. So that's all the way at 25%. And then we see that with other vaccine preventable conditions as well, where pharmacists have a role. So really low uptake as well with shingles vaccinations, and even with things like pertussis and tetanus. So we'll talk today about how to keep an eye out for who might be due for this, and how you can then play your part as a pharmacist in making this recommendation.
Yeah, this is a very interesting information, Tiana. And when you went through it again now, I noticed the lowest group is one of the groups that really should have some attention paid to them. And pharmacists often will have the information to identify whether that patient would be in the high-risk group for pneumonia vaccines, those with comorbidities. And we'll be discussing what those groups are a little bit later on. But, you know, we have a mix of pharmacies in the banner. Some pharmacists are very keen on screening for immunization status and providing those injections. And then we have some that work with a clinic space and maybe a little bit less involved in immunizations. But as we talked about that, you and I, we're really encouraging those pharmacists to still play that active public health role and identify which patients would benefit from vaccinations. And at the same time, I think it should be a part of every medication review you do with a patient, or every new patient you onboard to your pharmacy. You update the file and determine which immunizations are missing. So what a big opportunity for pharmacists.
I completely agree, James. And I think one of the things that came out of this survey as well was they asked people, they asked the Canadians who reported their vaccine uptake, they asked them, why haven't you been immunized against things like influenza and pneumonia? And the most common reasons for this were that they didn't know that there was benefit from being immunized and that no healthcare provider had actually recommended it to them. So exactly like you're saying, there's a big role for us to even just recommend these things and to track vaccine status. And later in the presentation, we'll talk about some tools that can help pharmacists because we know it's really busy in the community pharmacy setting, and these tools can help with that. Just a reminder that when we are making recommendations, you want to make a strong recommendation so they feel confident that you're confident in your recommendation. And we also want to take a proactive approach. So exactly like James said, when you get a new patient coming to your pharmacy, when you're doing things like a medication review, and even when you're dispensing other medications that show you they have a comorbidity, these are times to proactively make that recommendation. Okay, so we talked a bit about the impact of COVID-19 and quite a bit actually in our What the Flu webinar, which James led for us 2 weeks ago. So if you want to learn more about how to stay safe while offering immunization services during COVID-19, we'll refer you to that webinar. But we wanted to highlight that there are impacts of COVID-19 that make it the ideal time for pharmacists to really step up into this public health immunization role. So some of the things of that are that earlier in COVID-19, there was a lot of uncertainty, a lot of medical offices closing, even a lot of pharmacies temporarily pausing their immunization services. And so a lot of patients might actually be due or have had their immunization series disrupted. So we want to make sure we're proactively reaching out to those people and making sure they now receive those immunizations now that we know how to safely administer these doses. If their vaccine was interrupted, we don't have to restart the series for the vast majority of immunizations. It's okay to just continue the series, and when they finish the series, the patient will still receive the maximal benefit. One of the reasons why it's really important to do this is because COVID-19 is already stretching the limits of the Canadian healthcare system. If we don't immunize people, we risk them getting these vaccine preventable diseases and also needing attention from our healthcare system, which adds additional burden, and we might not have the capacity to treat them not only for COVID, but also treat people for influenza and hospitalize people and put them on ventilators for pneumonia, have them seen by their primary care provider for shingles, for meningitis. We just don't have the capacity. So we need to play our role in reducing that. We also know that there's been really increased awareness, like I was mentioning earlier. So it's a time where people are really open to pharmacy recommendations. So it's a good time to start integrating this into your practice. Now, one of the things you can do is to really optimize the encounter. So NACI recommends offering multiple immunizations at each interaction to reduce the number of different visits that patients have with the healthcare system. This is beneficial because it optimizes their protection. For example, with influenza and pneumonia, we're really keeping their lungs healthy, especially if they then perhaps get COVID-19. It's also helpful because the pharmacy can maximize their efficiencies. They can prep multiple vaccines at the same time. They reduce the number of times they have to wipe down the area and use infection prevention and control measures. And then it also reduces the risk of the patient because they're not exposed to other patrons on multiple occasions. It's just that one occasion. And the way that I like to break it down is really by age group. And that's how today's presentation will be done so that it can help you kind of zone in on someone based on their age and screen them. So we see things like influenza and meningitis B and HPV for the younger teens and adults. We see influenza and pneumonia or herpes zoster vaccine for adults who are 50 plus with comorbidities or 65 plus. And we see influenza and a Tdap vaccine for people who are pregnant.
Yeah, so Tiana, we've been hearing a lot across the country this year how flu vaccine doesn't seem to be readily available at pharmacies, at least not right now. And maybe that won't change, maybe it will. But I think we should try and use those opportunities where we're getting called for flu vaccines and then see if there's another vaccine we can help the patient with in order to protect them against another very serious illness. So for example, if someone calls and they're 65 years old and you're in British Columbia and you don't have high-dose flu vaccine available at the pharmacy, well, perhaps you could talk to them about getting their pneumonia vaccine or screening if they need that. And then also checking what their shingles vaccine status is. So maybe you can still do 2 vaccines at one appointment. Unfortunately, it might not be the flu vaccine that they asked for originally, but there's other ways we can protect patients as well in the middle of a pandemic when it's very important to do so.
Yeah, I completely agree, James. And some of our pharmacies have started integrating this into their practice even before flu vaccines were available or at the beginning where limited stock was available and they didn't have any left. And one of the common questions I get is, okay, how do I administer multiple vaccines at the same visit? And so our recommendation is to administer in different limbs. However, that might not always be possible for various reasons. If you need to use the same limb more than once, try to separate the injection site by about 1 inch or 2.5 centimeters. So we'll start by looking at adults who are 50 plus and the vaccine preventable conditions that we want to screen them for and immunize them for. So the first one is pneumococcal pneumonia. So pneumonia is predominantly caused by Streptococcus pneumoniae. And when that stays in one area contained, so like in the lungs, we get something like community-acquired pneumonia. When it moves from that site into another site that is previously sterile, that's when we get invasive pneumococcal disease. And that can be quite serious for patients. The most common serotypes that cause serious disease are 19A, 7F, and 3. And we know that pneumonia is quite serious. Not only does it lead to hospitalizations, but it can also lead to lung, kidney, and heart complications and death. So we know that along with influenza, pneumonia is actually in the top 10 causes of death for Canadians. So we really want to do our part to protect adults from pneumonia and associated complications. Now this begs the question, who's at risk? So we know people in extreme ages, so less than 5 or 65 and older, are at highest risk of pneumonia, as well as the associated complications. We also see adults who are 50 years and older with medical conditions. So I like to think of these patients as the at-risk patients. So they're patients with things like COPD or asthma, diabetes, or cardiovascular disease. We also see adults 50 plus who have other lifestyle risk factors that also put them at risk for pneumonia. So things like patients who smoke or who drink alcohol heavily. And then we have the highest risk patients who are those who are immune compromised. And this could be due to a medical condition. So something like not having a spleen or having cancer or being HIV positive. It could also be someone who's undergoing therapy. So undergoing chemotherapy or radiation or an immune compromising medication like a biologic.
Right, and Tiana, that's a very important slide. Can you just go back to it for me? Yeah, thank you. So we know, that there's gradations of risk within each group. So you can have very healthy seniors, 65 plus, yes, they're eligible, but There's younger folks that are even greater risk of suffering serious consequences should they uh, get infected with pneumonia. And pharmacists have the power to identify those patients. So you can screen patients 50 years and over, for example, if they're on inhalers for COPD or asthma, you can identify them as being higher risk, or they're on medications for diabetes or a cardiovascular condition. So we have a big opportunity to really select out from our patient population those who would benefit the most.
Exactly, and I think there's a role for pharmacists, but there's also a role for other pharmacy team members. Exactly like what James was saying, you can identify patients who have these medical conditions that put them at increased risk by things that are being dispensed. So it's a great opportunity for pharmacy technicians and pharmacy assistants to notice, okay, a glucometer is being dispensed, or an inhaler is being dispensed, and notice, okay, these people have a comorbidity that puts them at risk. Let's start that conversation either with myself or with a referral to the pharmacist to get them protected. And so there was a recent study that actually just came out in 2020 that was published in BMJ Open Respiratory Research, and it looked at Canadian data, and it looked at the burden of pneumococcal community-acquired pneumonia in hospitalized Canadian adults from 2010 to 2015. And they found that individuals who are hospitalized with pneumococcal community-acquired pneumonia were more likely to be hospitalized and to require ICU and ventilation if they had one or more comorbidity. So even though a lot of the patients that were evaluated were only 50 years old, they weren't in that oldest age group, they were still at really high risk because of this comorbidity. So if we only look at patients who are 65 and above and immunize them, we're really missing that 50 to 64-year age group where they have those comorbidities that could put them at risk of pneumonia, hospitalization, ICU stays, and complications.
Tiana, we have a question, and it relates to patients who are immune suppressed. So the question is, if a patient is on a biologic, they can get the flu shot or any immunization, which is not a live vaccine. Is that correct?
Yeah, so both of the pneumonia vaccines, neither of them are live vaccines. So those can be provided. I would do an assessment with the patient and their specific condition just to ensure that it is appropriate. And if you ever have any questions about the specific case, if you're with Whole Health, you can email me and I can find a specific study that's looked at it in this patient population. But in general, if it's not a live vaccine, it can be provided to the patient. If we're looking at how to be most proactive, if we know that a patient is maybe in an early stage where a condition in later stages of therapy has something like a biologic, perhaps something like Crohn's and colitis or something like arthritis, it's really good, even for the pharmacist in a meds check, to say, okay, I know you're on first-line therapy and we're not there yet, but should we make sure that your immunizations are up to date in the event that you do need a therapy later on that is immunosuppressing? One of the things you can also do is before starting therapy with something like a biologic, if the patient is able to delay start without delaying their wellness and outcomes, could they receive these vaccines before they become immunosuppressed?
That's a very interesting comment, Tiana. I had patients myself who were starting on biologics that would be immune suppressing, and they were getting updated, or they were being provided vaccinations that are usually indicated for much older adults, even though they were in my age group, the under 40 crowd. They were getting offered vaccines that usually you give to people 50 and over so that they wouldn't experience, for example, shingles.
Exactly. Yeah. Okay, so a lot of people are probably familiar with the pneumonia vaccines, but I'll just highlight the two that are available. There's Prevnar, which is a conjugate polysaccharide vaccine, and then there's Pneumovax 23, which is a polysaccharide vaccine. And one of the questions I get really often is, What's the difference and what's the advantage of the conjugate over the polysaccharide? Well, the advantages of the conjugate vaccine are that you get a more robust antibody response and you also get longer protection. Now, the reason for this is because the immune memory that it induces. When we look at the conjugate vaccine, it induces a greater IgG response, whereas the polysaccharide vaccine induces a greater IgM response, so you're not getting that long-term protection. You also see this in the fact that we re-immunize with Pneumovax and giving boosters, whereas we don't do this at this point with the conjugate vaccine. Another one of the advantages is that the conjugate vaccine actually offers herd immunity. So if we immunize enough people in a population, even those who aren't immunized will be protected and benefit from the fact that others are immunized. So sometimes, and this goes back to what James was saying with patients who are immunocompromised, one of the strategies we can actually use is that if our patient can't be immunized for whatever reason, the people around them can be. Okay, now it is recommended that you receive both vaccines if your patient is at risk. And the benefit of that is that you get all the benefits of the conjugate vaccine. You also get additional strain coverage. So there are some strains that are in the Pneumovax 23 that aren't in the Prevnar. And so by getting both, you get both of those strains.
Yeah, so Tiana, before we move on to the next section, I think this is a good point to ask a couple of questions that often come up. So one of them is around the two pneumonia vaccines. So if a patient has already received the Pneumovax, what do we do? Or if they haven't received any, where do we start?
Yeah, so if the patient hasn't received any yet, my recommendation, let's say for a 65-year-old, would be to start with the Prevnar or the conjugate vaccine. The reason for this is kind of twofold. The first being when you give Prevnar, you then only have to wait 8 weeks before you give Pneumovax. Whereas if you give Pneumovax first, you have to wait a full year before you can give Prevnar. So by starting with Prevnar, the conjugate vaccine, you're ensuring that the patient receives both vaccines and the maximal protection in a shorter amount of time. Whereas if we start with the polysaccharide vaccine and have to wait that full year, we're waiting a year where the patient isn't yet maximized in their protection. You also risk potentially losing them to follow-up since it is such a long follow-up with that full year instead of simply 2 months. The other reason why I recommend the conjugate vaccine first is that they've actually done studies looking at the immune response, and they found that when you give the conjugate vaccine and then the polysaccharide vaccine, you get a greater immune response than when you do it the other way around, or when you give two of the polysaccharide vaccines, one after the other. Okay, so I think this brings us to the role for the pharmacist. So we've really highlighted for adults who are 65 and older, there's a role for pharmacists to immunize them against Prevnar, as it's not publicly funded for this age group. And for adults who are 50 years and above with chronic conditions that put them at risk of pneumonia, so people with lung conditions, diabetes, heart conditions, liver or kidney conditions, or lifestyle risk factors like individuals who smoke, that would also be a group that doesn't currently in Ontario have public coverage for Prevnar, but would benefit from being immunized. In these cases, the patients may qualify for Pneumovax. So what I would recommend is after you as the pharmacist have immunized the patients using Prevnar, you then fax the prescriber to let them know that you recommended the patient now comes to them 8 weeks later for their Pneumovax vaccine.
So that's an Ontario recommendation because that's here in Ontario is publicly funded for certain groups, right?
Exactly. And so that's an Ontario-based recommendation. In Alberta, however, the nice thing about that province, among other very nice things, and one of them is that pharmacists actually have a public health role through the publicly funded Pneumovax vaccine for adults 65 and older. So in Alberta, it's slightly different where instead of having to refer back to public health or the primary care provider, pharmacists could actually do the Prevnar vaccine and then also Pneumovax 8 weeks later. Okay, so we'll move on to shingles or herpes zoster. So we know that herpes zoster starts as varicella zoster virus, and that starts in a lot of Canadians as chickenpox. It then lays dormant in the dorsal root ganglia and can reemerge as our immune systems are weakened as we age. And when that reemerges, it reemerges as shingles. And we know that it's actually really common for Canadians to get shingles, with 1 in 3 people experiencing shingles in their lifetime, or even 1 in 2 adults over 85 having experienced shingles. Now we know that it's more than just a rash, and there can be debilitating complications like postherpetic neuralgia, which can cause pain for months and even years. It can also cause vision loss if the herpes zoster occurs in the eyes. It can cause scarring that people might be very self-conscious about, and even infections, so secondary bacterial infections, for example. Now again, we wonder who's at risk. So adults 50 and over tend to be at increased risk because they have that immune system that's waning as they age. Those who have previously had chickenpox, again, those who are on immune compromising medications or who have immune compromising conditions.
Yeah, so Tiana, we've got a question that relates to that slide that came
Sure.
in earlier. So the question says they're seeing a lot of patients younger than 50 years of age that are experiencing shingles. So basically, is there any data or maybe ongoing studies that you know of or that might come out to address these younger age groups?
So I have seen Shingrix specifically used off-label for younger patients who are at risk and who might even have had shingles, and now we're waiting that year after the shingles and then immunizing them. That is something that has been seen. For some patients, you might even see that they end up getting shingles more than once, and so that's when they've said, okay, we're not going to keep waiting for them to hit 50. We want to make sure they're immunized. If you would like more specific information, and if you have a specific patient in mind, email me and we can see if we can find a study that's most relevant to your specific patient. It currently is indicated for adults 50 years and above, but I have seen an off-label use for it.
Yeah, and I did mention that earlier that I've seen that myself. Tiana, there's another question before you go on that relates to pneumonia. And the question is, how long are patients protected after the pneumonia vaccine?
Yeah, so it depends on which vaccine you're giving. Right now with Prevnar, it looks like there's no need to re-immunize. There's ongoing evaluations of that, so we might find out later that as they have more and more data, there's a need to re-immunize, but as it stands, it seems like they're protected, so it's just a once-in-a-lifetime immunization. For Pneumovax, we see that protection waning, and so patients who are immunized when they're younger, so younger than 65, because of a risk factor like a medical condition, like an immunocompromising condition, they will be re-immunized 5 years after that original vaccine, and then again when they turn 65, as long as it's been more than 5 years since that last dose.
Great questions. If you have any more, put them in the chat box.
Okay, so I'll keep going, but James, oh yeah, okay.
So if you get immunized, then does that mean no shingles? I guess they're asking about the effectiveness of the vaccine.
Yeah, I was going to say, as long as it's a shingles vaccine and not a pneumonia vaccine. We will talk about this in just a couple of slides, so let me keep going, and then if I haven't answered the question, let me know. So there are 2 herpes zoster vaccines available. They are Schedule 1, so they require a prescription, whereas the pneumonia vaccines are Schedule 2 vaccines, and so don't require a prescription for dispensing, although they might more for insurance coverage reasons. We have Shingrix, which is a recombinant zoster vaccine, which is not a live vaccine. And then we have Zostavax 2, which is a live attenuated adjuvanted vaccine. So a key difference there being the live versus non-live, and that impacts the patient populations that we can safely use it in. The advantages of the recombinant zoster vaccine include greater vaccine efficacy, both in reducing herpes zoster and in reducing postherpetic neuralgia. So when we look at the different studies for Shingrix versus Zostavax, we found that with Shingrix, there was greater than 90% effectiveness in reducing herpes zoster, and that was maintained across the different age groups. So from the 50 to the 70, 80 plus age categories. Whereas when we looked at the live vaccine or the Zostavax, we see much lower efficacy against herpes zoster, and we don't see that maintained across age groups. So we actually see protections, more overall protections, more in the 50s and 50s rates, and even reducing all the way down to about 40% in the older age groups. We also see that with the recombinant zoster vaccine, the efficacy seems to be maintained over time. So they have immunogenicity data up to 9 years, and that's just because it's a newer vaccine, so it's still being monitored. But at this point, it looks like that's maintained. Whereas when we look at the live zoster vaccine, we see a reduction, a significant reduction, even 1 year post-immunization. And at 5 years after immunization, it becomes a point where we don't even know if it's providing protection against herpes zoster anymore.
So Tiana, I was going to jump in with a question that relates to that. So you kind of already addressed it, but maybe you can reiterate in case the individual wants to have attention drawn to it and they missed it. So with regard to Shingrix, they have the understanding that it's a once in a lifetime vaccine. Don't forget it's a series of 2 doses. But does immunity wane over time? Last I heard is they have studies showing immunity for 4 years, but not sure if it's been extrapolated for longer.
Yeah, so exactly. So at this point, and we kind of touched on this, it looks like it is sustained when we look at the first 4 years that were looked at in humans, where we actually evaluated the herpes zoster rates. There's some immunogenicity studies, so not in terms of the outcomes, but more in terms of the immune response, where we see at 9 years, it still looks like there's that protection, but it is ongoing where they are evaluating if that efficacy is maintained for even longer. So stay tuned for that in coming years. But at this point, it doesn't look like beyond the 2-dose series, there's a need to re-immunize. Okay. Now, this is really hot off the press, I think, and it's a public funding update for Ontario, and I will turn it over to James for this.
Thank you, Tiana. Yeah, this is big news, and it's good and bad news for pharmacy, I would say. So now that the Ontario, we're going to start publicly funded. Actually, it said starting in mid-October, so we're late October now, and I've been starting to hear about patients being directed to their primary care providers to receive Shingrix vaccines. So what that means for pharmacy is that the age group between 65 and 70 can now access Shingrix through their primary care providers. So there's some groups that we're going to identify in the next slide that pharmacy can hone in on and still look at that as an opportunity to vaccinate for Shingrix. So keep in mind that with this policy, it does not include individuals between 60 and 70 who have already received Zostavax through the publicly funded program, which is an interesting decision in itself because we know the comparative immunogenicity between those 2 vaccines is quite different in terms of Shingrix being far superior. So there is a bit of a bridging program happening in those individuals born between 1949 and 1950. they are eligible to have the 2-dose series as long as they complete it by 2021.
So this is what James is alluding to here, where there is a continued role for pharmacists in Ontario in providing herpes zoster vaccines. And you can break this up into 3 age groups, I would say. The first is the 50 to 64 years old age group, who they might not want to wait those extra 14 years before they're eligible for publicly funded herpes zoster immunization, as they might be concerned about the risk for shingles and post-herpetic neuralgia associated with that. And they might also currently have private funding in order to receive Shingrix, so they're okay with getting it right now, and they'd like to have those extra years of protection. So there's that age group. There's also the people, like James said, who might feel like they really missed out, and it was a bit unfair for them because they kind of were right on their protection and they got their Zostavax between 65 and 70, but that precludes them from being eligible for the publicly funded Shingrix. And so they might feel like they want that best protection that's now the standard of care. And so there's a role for pharmacists to immunize them. And that can really help them feel like they're getting attention from the healthcare system that maybe they otherwise might feel a bit missed. And then there's the patients over 71 who were either immunized with Zostavax previously or haven't been immunized, and they're at that greatest risk as their age becomes older and older. And so we want to keep recommending Shingrix for this age group, as we know efficacy is maintained across the age groups.
Yeah, this is a really great slide for pharmacists to kind of visualize their patients and who might they hone in on for providing shingles from the pharmacy. And what I see in the middle, it kind of mirrors for me what happens when Shingrix came on the market. And what I did at my pharmacy, I looked at which of my patients had already received the Zostavax, and after discussing with those patients, sent out the recommendations to their prescribers so that I could update their immunizations. So those patients who are in that middle group especially, they're missing out on the best shingles vaccine, and you can offer them one that protects them better. So it's a great opportunity to help those patients maximize their protection against shingles. And when they hear about that opportunity, often they'll jump at it.
Yeah. And then for those of you attending outside of Ontario, currently herpes zoster vaccines are not publicly covered. So anyone 50 plus would be a great patient to intervene on and provide this immunization to. Okay. We'll keep going with a focus shifting to adults 15 to 25 plus. So more of that late teen, early young adult age group. So the first one that we'll start with is meningitis. So meningitis is a serious bacterial infection which is caused by Neisseria meningitidis. And the most cases in Canada are due to serogroups A, B, C, W, X, and Y. And when we look at the breakdown of it from Canadian data, we actually see that meningitis B represents the majority of cases at about 67%. So one of the reasons for this is that there are publicly funded programs in a lot of provinces against ACWY, but there aren't against meningitis B. So that's where we see patients continue to be at risk and don't even realize that they're still at risk because they think, oh, I got my meningitis vaccine in school, when really they got a meningitis vaccine in school, but not that complete protection in all provinces. Now we know that the consequences of meningitis are very serious and they occur very quickly. Meningitis can be deadly within 24 hours of the first symptoms. So we want to make sure that patients are protected to really give them the best chance of this not occurring. Oftentimes it results in death. Even if it doesn't result in death, it really results in debilitating soliloquy, things like limb amputation, neurologic disability, and hearing loss. This can be especially tragic because when we look at who's at risk, there's 2 age groups, one of them being kids, teens, and young adults. and those living in crowded areas. So these are the patients who are really at risk of meningitis B, where those complications like limb amputation can really affect them for the rest of their long lives if they survive. We also know that they're at risk because transmission occurs through close direct contact and sharing saliva. So activities like kissing, sneezing, sharing drinks, utensils, cigarettes, things that occur when students go to university and college, live in dorms, when they go to summer camp and they live in close quarters, or if they're living in military barracks, for example. We then also get groups that are at risk of meningitis A, C, W, and Y, and those are largely travelers, so people who go to areas like the meningitis belt or on pilgrimage.
Tiana, there's a question that relates to shingles vaccines.
Sure.
And I don't know if you'll have the answer off the top of your head, but we can try. So if someone has had Zostavax and interested in Shingrix, is there a period of time to wait between the two?
Yeah, so what NACI recommends is waiting a 1-year time frame. One of the reasons for this is at least they can get something from that Zostavax vaccine. So they get that 1 year of benefit, and then we see that significant decline in protection. And so then we're going to give them a Shingrix vaccine. That's also a similar reason to why we wait a year after someone has had shingles before we give them their Shingrix vaccine. And again, we want to kind of ride that benefit of the patient's natural immune response to shingles for a year. And then as that's waning, we immunize them to give them additional protection. So it typically tends to be a year. You can do it sooner, but a year is what I would recommend. Okay. So when we look at meningitis B, there are 2 vaccines. There's Trememba and there's Bexsero. And when we look at meningitis ACWY, there are 3 that are currently on the Canadian market. So there's Nimenrix, Menveo, and Menactra. And the role for pharmacists here, I would break it down into 2 age groups. So there's that meningitis B protection for the teens and young adults. And because it's not publicly covered in most provinces, keeping an eye out for students who are graduating, who are going off to camp, who are moving away to university, this would be an excellent opportunity to immunize them. Keep in mind that it's a 2-dose series, so we do want to start in advance. So maybe as soon as they graduate, so that when they're home for winter holidays, for example, they can finish the series, or even starting them in September of their graduating year, so that by the time they graduate, they have that full protection before they go off the next year. And then when we do start traveling again, travelers might be at risk for meningitis ACWY, especially people born before 1997, as it wasn't previously in public immunization programs. Those people might only have protection against meningitis C, for example. Okay. Now I'll move on to HPV vaccination. So HPV, or human papillomavirus, is the most common STIs, and it can lead to things like cancer, things like anogenital cancer, cervical cancer, oral cancers, as well as cancers of the neck, and genital warts. What we see here is different types of HPV. We have high-risk HPV types, so those in red, and we have the low-risk HPV types, the ones in this maroon color. So the high-risk types lead to cancers, and the low-risk types tend to cause genital warts. And so one common question is, what's the difference between HPV-4 or Gardasil-4 versus Gardasil-9? And so with HPV-4, we see that 4 types were protected against, whereas in the Gardasil-9, we have these 9 types, which includes additional of the high-risk HPV types that cause cancer.
So Tiana, there's a couple important questions that relate to this, and I'll give you one at a time. So What do you do if you encounter a patient and they've already had the Gardasil 4-valent series, but they are hearing about this new Gardasil 9, or newer, I should say? What should the pharmacist do in that case?
Yeah, so NACI recommends that this kind of evaluation and decision be done on a patient level. So I would say the role of the pharmacist is to explain to the patient what the differences are and help them make a patient-centered decision based on their circumstances. So you can let them know that the HPV-9 vaccine covers against additional HPV types that cause cancer, whereas the HPV-4 might have less coverage against those cancer-causing types of the virus. This can be more or less important depending on the patient's circumstances. So for example, if it's an older patient who is in a monogamous relationship, who they think will be in that relationship long term, they might not have as many risks for being exposed to additional HPV types. And so for them, maybe the HPV-4 was adequate. Whereas for a younger patient who might not yet be sexually active or is recently sexually active, and so they haven't been exposed to as many HPV types and might continue to be exposed through different partners throughout their life, they might want those additional strain coverages to protect them from different encounters. So it becomes a decision really for the pharmacist and the patient to jointly make based on their circumstances and based on the amount of protection they feel most comfortable with.
The other question is not specifically just for Gardasil, but when we're talking about vaccines in series, so we talked about Shingrix, now we're talking about Gardasil, it's not just one dose. And through the pandemic, there's been a lot less access to healthcare in person. So what should the pharmacist do if they come upon a patient now that started their Gardasil series or their Shingrix series last February, and then the pandemic struck and they haven't had the subsequent doses? What should they do?
Yeah, so I think it's really important, and there actually is a role for pharmacists in running reports, which we'll get to a bit later, to see, okay, who had one of these vaccines dispensed? And when I look at their profile, did they have all 2 or 3 in the series dispensed? Do I know that they actually finished the series? If not, let me connect with them to ask them to come in and finish that series. So there's that proactive role. We do want to help them finish that series so they have the maximal protection, as they won't have it until they finish this series. One of the nice things, though, is that the Canadian recommendations are that you don't have to restart the vaccine series. You just want to complete it. There are some exceptions, things like a rabies vaccine, for example, but for the vaccines we're talking about today, none of them have to be restarted. Okay. And this probably happened quite a bit, especially as offices were closed, as pharmacies may have quieted down on their immunization services earlier in the pandemic. So you might be seeing quite a bit of this. And taking that proactive role now can really help us get back on track with immunizations instead of waiting even further, where a lot of people will end up being due at the same time or overdue at the same time. And that can put strain on the healthcare system. Okay, so I'll keep going with HPV. And when we look at the role for pharmacists and who's at greatest risk, there's a few different categories. We have highlighted here patients who went to school outside of Canada. We know that in Canadian middle and high schools, in more recent years, we've integrated HPV vaccines for females, and in very recent years for males in most provinces across Canada. But there remains a large role for people who are educated outside of Canada who might not have these publicly funded immunizations as a school-based program. And this can be people in nearby colleges or universities. So if your pharmacy is nearby a college, there's a great opportunity to outreach to that school and create a relationship to make sure that their students are protected, especially because their university or college health plan might have vaccine coverage in it. There's also an opportunity for immunizing people who graduated before the public program was implemented, and this is especially relevant for the male patient population. This, we then talked about coverage for additional strains and that decision for HPV 9 versus 4. So there might be a role for immunizing with the Gardasil 9 if someone previously received a vaccine with less coverage. And then just re-emphasizing that it's for males and females 9 years and older. So some questions that I get are, okay, well, my patient is 35. Is there still benefit of immunizing them? And there can still be benefit, especially if they're going to have different new partners, because yes, they might have been exposed to some HPV types already, but they likely haven't been exposed to all of them. And so if we immunize them, then they have protections against those additional types that they haven't yet been exposed to. Now, we've talked about how to screen patients and where the role for pharmacists really lies. We'll now talk about how to integrate immunizations into the pharmacy workflow. So during influenza season, but really beyond.
Yeah, and we're coming up on an hour now, Tiana, so we'll try and move through these last bits a little faster. So this is really going to highlight for folks who are not part of the banner some of the resources that are available with Whole Health, and maybe remind some of our own pharmacies that we do have these tools available. So we do provide guidance on how to run reports to select particular patient groups. So this is an example with Krol on how to run the reports for identifying patients by age. And so, for example, if you want to identify patients who would benefit from receiving a meningitis vaccine, you would just have to plug in the years 15 to 25 years of age, and that will spit out a report of all of your patients in the database that are in that age group. Alternatively, like what I would use it for is during flu season, with pre-booking my high-dose patients that would need a high-dose flu vaccine, I would run like age 65 to 100 and filter out those patients. And similarly, you can run the same type of report with Fillwa. So with Whole Health, we have a number of softwares used by our pharmacies. So we try and give tools for the various dispensing softwares. So with Fillwa, you can also run a list of your patients by age. We also give guidance on how to look for example, if your patients have received other vaccines, so you know that, this is a patient that likes vaccines, I'm going to see what else they might need.
Yeah, and we also have ways to integrate this into influenza season, like we've mentioned. Now that we've moved into more of an appointment-based model, especially for flu shots, this is a great opportunity to have patients self-screen in advance. So you can have vaccine screening tools available on the website or your pharmacy's website for patients to download and then bring in completed. You can also do it with them over the phone. And one of the nice things that we've integrated here in section 4 is an immunization screening questionnaire. And again, based on age, asking the patients, are you over 50 and have you received a pneumonia vaccine? Are you over 50 and have you received a shingles vaccine? And are you between 15 and 24, have you received a meningitis B vaccine? And so this gives the pharmacy team a bit of a heads up as to if the patient might be due or not, and it gives the team an opportunity to then fax whoever they need to get additional information or prescriptions. So they can contact the primary care provider to get an immunization history. The patient could look with public health to get a record there. And then if a prescription is needed, either because it's a shingles vaccine and it's Schedule 1, or it's a meningitis vaccine and a pneumonia vaccine, and although it's Schedule 2, the patient has private insurance and requires a prescription, then the pharmacy can fax in advance to get these prescriptions and have the vaccine waiting for the patient at their flu shot appointment. You could also do this in other practice and fax the prescribers in advance, so you have the vaccine waiting the next time they pick up their medications or when they come in for their meds check, for example. Now, one of the tools that Whole Health created, and it's based on Immunize Canada's resource, is this pocket card, which can be provided to the patient to help them track their immunization status. We know that as youth or less than 18 years of age, public health has a good system where they keep track of vaccines provided. Whereas when we become adults, the onus really becomes on us, and it can be really hard to track this, especially if we're changing primary care providers, we're getting immunizations from different resources like public health, the pharmacist, the physician. So you can print these out and have them available for patients. It shows them which vaccines are recommended for healthy adults, and it highlights at what age point these are recommended. So it becomes really easy for the patient to realize, oh, I'm 20 years old. This means I should make sure I've had my meningitis B vaccine and a Tdap vaccine. Or, oh, I'm over 50. Let me make sure I have my shingles vaccine and my pneumonia vaccine. And it's kind of a nice cheat sheet for pharmacists as well, not only because of the age information, but because we've included vaccine recommendations info. So if you need a little reminder, this can provide good guidance on who would be good to immunize and who you might want to refer to public health instead. Now, in order to actually get prescriptions, like we mentioned, we have developed pharmaceutical opinion templates. These can be used either as pharmaceutical opinion templates or even pharmacy recommendation templates, where there might not be that reimbursement, but it helps make the workflow more efficient and make your recommendation more evidence-informed. So we have included background reasoning for why the immunizations are appropriate, with references so the prescriber can look it up and really trust your recommendation. And we've pre-populated with risk factors as well as recommendations. And so it makes it faster for the pharmacist to simply check off the appropriate boxes, and helps act as a bit of a reminder too in terms of which patients might be at risk. For Ontario, we've developed an updated shingles pharmaceutical opinion template and one for the rest of Canada, reflecting the new publicly funded immunization program. We also have campaign materials, which all of our pharmacies have received, and we'll be following up with everyone to see if you have any additional questions. And there is an additional resource that I'm bringing to light here. It's an operationalizing adult immunization webinar, which goes into a bit more in depth about some case examples for patients, as well as COVID-19 and the impacts on immunization services. So I'm also the speaker for that, but this is hosted through the OPA. It does also feature some whole health tools like we've reviewed today, so you can see them there as well. Okay. So thank you. Yeah, I was going to say thank you so much for joining us. If you're not part of the banner, but you'd like some of these resources, do email me there or James. If you have any questions that come up or need specific literature specific to a patient situation, feel free to email myself as well, and we can find that for you.
So Tiana, we're at the end of this presentation now, and I don't see any new questions coming in, but if you had to give, like, what is the most overarching important thought you'd like to leave the audience with, what do you think that would be on this topic?
I think the biggest thought would be that there is a role for pharmacists and pharmacy team members to work together to take on the different roles within immunization services and to proactively make these strong recommendations to make sure that our patients are protected at a time where they're really concerned about their health and they're really interested in doing what they can to become as protected as possible.
Great. So I'll say thank you, Dr. Tilley, and we'll say good night to the audience. Thank you, everyone, for joining us.
Thank you, everyone.
Have a good night.